Hi, I'm Mandy Colsey, and this is Clinical Connections for Unit 4. So first off, I liked case number 1, so that's the first one that we're going to look at. In this one, it says a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. So it asks which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation. So that's what we're going to take a look at. So first off, if we look at a blood glucose, this wouldn't be the best test to differentiate between if it's a beta oxidation disorder or a urea cycle disorder, because an elevation could mean lots of things. It could mean a problem with glucose metabolism or beta oxidation, or even a disorder of the urea cycle could cause increased blood glucose. So that's really not going to tell us a whole lot. B is the urinary acids. So the type of urinary acids could specify a problem with beta oxidation. Sorry about that. The type of urinary acids could specify a problem with beta oxidation or the urea cycle. So if she had increased uric acid or orotic acid, that would point to a problem with the urea cycle. And an increased level of dicarboxylic acids, that could point more towards a medium chain acyl dehydrogenase deficiency or something in the beta oxidation pathway. And also the presence of ketones in the urine would help to differentiate between a deficiency in one of these two pathways. The absence of ketone bodies would point to more a problem with beta oxidation. So it looks like that's probably going to be our answer in this one. If we look at C, serum fatty acids, this would be useful in detecting a problem with fatty acid oxidation, but it would be useless in ruling out problems with the urea cycle. And then D, plasma glutamine. This would be an important test to rule out a glutamine synthetase deficiency or a problem or another problem in the urea cycle, but it would tell us nothing about beta oxidation if there was anything going on there. So it looks like our best answer here would be B, urinary acids. So then it says a full blood workup was ordered for this female, and it tells us that first of all, the initial blood ammonia level was elevated, and it rapidly rose even higher from 314 to 600. The urine orotic level was also markedly elevated at 473 micromoles per liter. But then also it's important to look at this plasma citrulline level, and that was normal. It's a little bit on the low side of normal. So in this patient where orotic acid levels are elevated, it says to list one urea cycle enzyme that is most likely deficient and one enzyme that's the least likely to be impaired. So obviously the high blood ammonia, that's the main thing we're looking at. That tells us right away that something in the urea cycle is malfunctioning, causing toxic levels of ammonia. The elevation of the orotic acid narrows down the problem a little more. It's an indication that carbamoyl phosphate is accumulating. And because of a deficiency in the urea cycle here. So this excess carbamoyl phosphate, it would be used to synthesize pyrimidines in a separate pathway, and that's what's going to produce that extra orotic acid. A deficiency in carbamoyl phosphate synthetase right here, that appears to me to be the least likely enzyme to have a deficiency or a disorder in. This excess product of carbamoyl phosphate and the downstream orotate indicate that the reaction catalyzed by this enzyme is working well because it is synthesizing Yes, anyway, it is creating this carbamoyl phosphate. Also, if we look downstream here, we can assume that, here, let me move my picture out of the way. So here we can assume that this arganosuccinate synthetase and the arganosuccinate lyase are working correctly because this citrulline is not elevated. If there was a problem in one of these two enzymes, you would have this big accumulation of citrulline because it can't be processed any further downstream. So that can rule out both of these right here. So the most likely cause, if we're looking at this for this infant symptoms, is an impairment of this enzyme here, the ornithine carbamoyl transferase. It's also called ornithine transcarbamylase. And this is the enzyme responsible for shuttling this extra carbamoyl phosphate out of the mitochondria as citrulline. A deficiency would explain why the citrulline levels are somewhat low and carbamoyl phosphate is accumulating. So an infant onset of this disease in females is extremely rare according to the research, but it is possible according to these sources here. So that's case number 1. Now if we look at case number 3, it tells us that a 47-year-old man presents with severe pain in his right great toe. He's unable to bear weight on his right foot and there's no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed, and the results are listed. So here we can see what we've decided. His plasma urate is definitely high because it's greater than 7.0 here. The interesting thing is that his urinary uric acid is lower than normal. So it asks us, what is the best explanation for the presentation of gout in this individual? And then explain why the other choices are not consistent. So it lists these different things. Number 1, the overproduction of purines. So if this were the only problem, there would be an increase in the uric acid in the urine as well as in the plasma. So this could be part of the problem, but it's definitely not the only problem, because if purines are being produced, they're not being excreted. So number 2 says a decreased salvage of purines. So this would also cause an increased rate in excretion of uric acid. Instead of purines being recycled through the salvage pathways, they're going to be degraded to urea, which is excreted here. So we would see that increase. And then also to compensate for the loss of purines, purine synthesis is increased, which will contribute to the problem here. So then finally we look at answer number 3, decreased urinary excretion of uric acid. The urinary analysis shows that the patient is excreting a lower than normal amount of uric acid. And a decrease in excretion alone could probably account for the increased plasma urate, although there's a good chance we could have an overproduction of uric acid as well. So this tells us that we need to be looking for causes for a decreased acid output. So in the next part of the question, after further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that the fake sugar diet soda was bad for him. And he tells you he drinks between 4 and 5 liters of soda a day, which is very alarming to me, whether it's diet or regular. That just seems crazy to drink that much soda and not expect to have some sort of sickness. So obviously the primary sugars in these sodas is going to be fructose or high fructose corn syrup, which we all know is bad for us. So ask, what's the potential impact of this dietary modification on the presentation of gout? Which I think is a great question. Sorry, continuing on. So the potential impact of this dietary modification, the high levels of fructose in this patient's diet from all this soda are very relevant to his symptoms. In fact, this study from 2013 specifically finds that raised levels in uric acid linked with fructose consumption are caused by decreased excretion of uric acid. So it doesn't explain the exact mechanism for this, but there is definitely a correlation here. There are also lots of other studies that can link gout with high fructose intake. According to our textbook, in chapter 20, it tells us acute, and this is quoted, acute loading of the liver with fructose, as can occur with intravenous infusion or following very high fructose intakes, causes sequestration of inorganic phosphate in fructose 1-phosphate and diminished ATP synthesis. As a result, there is less inhibition of de novo purine synthesis by ATP, and uric acid formation is increased, which causes hyperuricemia, which is the cause of gout. So that's what our textbook tells us about it. And then finally, this source here. This article adds that in addition to the above, as stated in the textbook, that large amounts of fructose are converted to lactate in those alternate pathways. And then the lactate accumulates and it starts to compete with uric acid for excretion. And this would explain why serum levels increase while excretion of that acid decreases. And another interesting idea to note that's listed here in this article, it says that intake of substances that acidify urine will increase reabsorption of uric acid, which is a weak acid, rather than its excretion. So I don't know if regular soda is more acidifying to the urine than diet soda, but it could definitely have a part to play in increasing urate in the plasma and contributing to that uricemia, which of course leads to gout. And these are the other articles here that I have used. That's the end.